Thank you for the kind invitation to this meeting, and I'm very honored to participate. So, fresh from the oven, endoluminal shockwave lithoplasty is the topic. Let's get right into it. These are my disclosures. So if you look at needs in the vascular bed, we have to look on randomized controlled trials and see the exclusion criteria. And if you look here at the inclusion-exclusion criteria for the IMPACT study, you see, able to walk without assistive devices, like this lady, she would have been excluded. And then one of the first ones is angiographic evidence of severe calcification and chronic kidney disease. However, these patients show up in outpatient, with walking devices and with chronic kidney disease and with calcification. And here you look what we are talking about, this is the Schwindt calcification. There's also the PAC classification now about calcium. And so what does this look like on a histological level? Here you see OCT images of calcification, which puzzled us when we did this procedure. And actually, in the end, you can find bone tissue inside the artery. So what happens is lymphocytes, leukocytes get into the fat plaque and to the cholesterol plaque and morph into bone vessels. So how do we treat this, or how did we used to treat this? This is a patient with a CTO, heavily calcified, and you see that 40 atmospheres of pressure did not change this calcium. And so this new IVL technology is probably the way to overcome that. Here you see a short video how this works. A short current is put out by a generator and gets to these small emitters inside the balloon. This is the coronary or BTK version of the balloon. And this short current leads to small gas bubbles that you can see in the next slide. And the collapse of these gas bubbles send out shock waves, and these cracks the calcium intraluminal and also in the media. And here you see how this looks on magnification. And this is how the energy is emitted. And this leads to an equivalent to 50 atmospheres of atmosphere just working at the vessel wall, at the calcium. So what data do we have on this? This is was presented by Andrew Holden at CIRSE in 2018, the PAD2 trial. More than 90% of these patients had moderate to severe calcifications, 10 centimeter long lesions. We see that this technique is safe with a very low rate of major adverse events. And we see here as a standalone therapy, we have a patency of 70% after 12 months and freedom from target lesion revascularization of 80%. And this works also in a live setting. This was a live case that we did at Charing Cross, a severely calcified SFA. We were treating that with lithoplasty with a fairly good result in the end. So where else can we use this? Where are other fields to use this technology than the femoral-popliteal vessels? Here you see a nice example of a patient with a branched EVAR, and the branch to the celiac trunk did not open due to aortic calcium. And here you see in the end, after applying quite a lot of pulses, I think over 200, how the calcium opens when the balloon is open to 8 atmospheres. And note, high pressure balloon failed here to open this. Here another case, stent recoil in the superior mesenteric artery. High pressure did not open that, balloon ruptured. And after IVL, we were able to open the stent and restore flow to the mesenteric artery. Where else can we use this? The CFA, last fortress of conventional surgery. Here we have a 61-year-old academic with bilateral common femoral occlusion. And his time plan did not allow him to have open surgery. So he traveled to Münster for treatment. We recanalized this in an antegrade retrograde rendezvous technique, puncturing the SFA and coming crossover. And atherectomy failed on this one, but lithotripsy was able to open the vessel. And then we finished with a woven stent to create a lumen. And you see that there's quite a nice result in the end. And 6 weeks later, we came back for the left side, so puncturing through the stent actually on the right side, and then recanalizing on the left side, and also after IVL finishing with a woven stent. And here you see a functional angiogram with 90-degree bended thigh, and you see how good the stent works here in this case. And we published this already in a collaboration with Marianne Brodman from Graz. We published in Journal of Endovascular Therapy last year the acute results in treating the CFA with lithotripsy. Here's another nice case that Dr. Miller shared with me from Fort Collins, Colorado, treating the aorta, and you can nicely see how the 7mm balloon opened the lumen of the aorta. And another field of application you can see here. This is a case similar to one of the complication cases we just saw, where an endograft was not be able to be delivered. The nose cone got stuck here, the pusher broke sideways, and the iliac is ruptured, and we had to repair it with a limp. And here you see how this techniques can help in similar cases. Here's subtotal iliac stenosis, bilateral, and AAA on top. And this is also a case we did live. We prepped the iliac artery with shockwave lithotripsy. Here you see the pre-image, and here you see after treating it with 7mm IVL. And then smoothly delivery of the endograft. And note, we did not put any additional stents here in the bifurcation. And here you see the CT control after 6 months. And you see that both limbs of these endograft have equally expanded to about 8mm. This was quite helpful to crack the calcium up front to open the endograft completely. And I conclude, intravascular lithotripsy is a novel approach to address calcium, which may reduce the need of adjunctive stenting and other techniques. It enables successful delivery of EVAR and TEVAR systems. We can use it in a variety of vascular beds with excellent acute results. And it may facilitate full and unrestricted stent graft expansion in lesions that are otherwise difficult to crack open. Thank you for listening.
Thank you very much. It was a wonderful lecture as usual, and thank you for sticking to time. That's wonderful and quite thoughtful of you. We will probably have questions in the end if we have time. The next speaker, Dr. Sriram Narayan. He's from Singapore, and the title is Deep Dive into Pelvic Congestion Syndrome. And after him would be Dr. Woolen, who's been incidentally our fellow in Indraprastha Apollo Hospital. And after training in endovascular interventions under me, she's actually blossomed out to be one of the very good and leading interventional cardiologists and vascular interventionists in Indonesia. So I think if Dr. Woolen is around, let's have her lecture first and before she joins in.